So I thought we'd focus in on advanced care planning discussions today, because palliative care is a big topic, and this is certainly a very important part of the conversations that we have at the end of life with patients. And specifically in my role, I work in a community team in Sydney, and we offer also an in-reach service into residential aged care facilities. So I have this conversation with people quite a lot if they haven't started having these conversations already early on in the piece. So just with starting off with the definition from the World Health Organization, palliative care improves the quality of life of patients and that of their families who are facing challenges associated with life-threatening illness, whether physical, psychological, spiritual, or social, and the quality of the caregivers improves as well. So the word palliative actually comes from the Latin word pallium, which implies a cloak, and implies a form of caring that recognizes that cure, long-term control of the disease is not possible, and is concerned with the quality rather than the quantity of life. It cloaks troublesome symptoms and distressing symptoms, with the patient comfort being the primary aim of management. The palliative approach considers all of these things. We work with a multi-professional team from staff specialists, registrars, nurse practitioners, CNCs, social workers, occupational therapy, physiotherapy, etc. And we have an arm of, obviously, of our service that sees people in their own private homes and who want to die at home, and also those that want to die in their place of shelter, which might be a residential aged care facility or a group home. It's an approach that affirms life and regards dying as a normal process. We help to reduce families' anxieties around the residents' decline by discussing what's going on and what's happening, and trying to provide support to people when they're going through a difficult time. The approach is not to hasten, but neither to postpone death, and also to provide relief from pain and other distressing symptoms. We offer a support system to help people live as actively as they possibly can until they die. We also consider listening to patients' wishes and needs and concerns. This is a lot of what we do, is having these discussions, whether it be around advanced care planning or whether it be about other things, anxiety, existential distress, questions, just general information. Obviously, we consider pain and symptom management is a big part of what we do. We talk to people, and often our patients are still having active treatment or want to discuss treatment options. We also integrate cultural, psychological, and spiritual aspects of patient care, which is also a very important part of what we do, showing people dignity and respect, and ongoing discussions with patients and families and other stakeholders. And this is where advanced care planning conversations come in, because they change over time. They might start off as one thing on a new diagnosis, but they might end up very differently months or years down the line. So advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal is to help ensure that people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. And it's a dynamic conversation that changes over time. How are patients identified for this type of conversation? Ideally, people would start having these kinds of conversations when they see their GP. Those aged 75 years and older, for instance, attending their annual health checkup, might have this conversation with their GP. And there's a movement called the Advance Project, which is involved in educating GPs and practice nurses on how to have these conversations. And it is gaining traction. Actually, we find more and more people are open to having this kind of training. Any patient aged 18 years and over with one or more chronic or progressive illness, and this includes malignant and non-malignant conditions. All patients who meet the above criteria, given they are elderly or have a chronic progressive illness, would be appropriate for an early introduction to advanced care planning. Catherine Mannix is a wonderful physician, palliative care physician in the UK, says, "We tend to call them difficult conversations, but I think we make it difficult by calling it a difficult conversation. And what we're actually having is a tender conversation." The research shows that what patients value from a relationship with their healthcare professional is empathy and kindness, as well as confidence and expert knowledge. People want to feel safe, they want to feel held, and they want to feel that they've got a good and competent team around them. They respect and prefer honesty and balancing realism and hope, and a healthcare professional who shows understanding and sensitivity, and also encouragement, encouraging people to try and live as fully as they can until they die. So the prepared framework, which is something that was brought about through the authors below, through the Clinical Excellence Commission. This is an acronym for remembering what, how to sort of have these conversations. So preparing for the discussion, ensuring that the patient has whoever they want there, that they're having it in a place where it's quiet and you can have a conversation without being interrupted, etc. Being able to relate to the person and establishing rapport, eliciting understanding, what the person understands of what's happening with them and what stage of the disease that they're in and what their preferences are, providing information in a transparent way, and acknowledging people's emotions and concerns. When we see people are distressed, that we actually say to them, I can see that you're very distressed. Would you like to take a break, or would you like to continue having this conversation, or should we move it to another time? Realistic hope, encouraging questions from people so that they're informed about what's happening to them, and obviously documenting all of this information. So tips on starting conversations about deteriorating health. And I think all of these phrases are very useful because they're segues to actually get, starting a conversation. So the first one is, I wish we had a treatment for your bladder cancer, for instance, but could we talk about what we can do if that's not possible? And the second one is, I'm glad you feel better and I hope you will stay well, but I'm worried that you could get ill again. And there again is another segue for talking about what could happen down the line and in the future, things change. The third one is, can we talk about how we might manage with not knowing exactly what will happen and when, if things are a bit uncertain? And the next one is, if you were to get less well in the future, what would be important for us to think about? And by saying the word us, you're actually including yourself in the treating team and letting the person know that you're on their side and you have their back. The last one is, some people want to talk about whether to go to hospital or to be cared for at home. And this is very important. I had this conversation with an elderly gentleman today, 90 years old, that never had an advanced care planning conversation. And the family is nervous about approaching this conversation. This man is clearly very unwell and is not going to live for very long. But it is important because he needs to have a say in the matter about what he wants to happen to him. So all of these things are good practical ways of actually starting these conversations. So there's choice in having, there's dignity in having choice. And not so long ago when Prince Philip died, apparently he had a lot to say and he was very involved in actually his own funeral and where he wanted to be when he died, which was in his own bed in the palace with his wife by his side, who he wanted at his funeral, what sort of music he wanted played, what marching bands or military bands he wanted, who he was giving his carriage and horses to one of his grandchildren. So there was a man who actually, without knowing it, was nearly 100 years old and actually took an active part in advanced care planning and planning his own, how he wanted things to look. Some people might want this. They might just want to be in their own bed or in a nursing home or whatever, and they might want their cat on their lap or the dog or just a couple of people around them. But very few people want this. And so it's important to have these conversations with people about how they want things to look in the future and going forward. So the evidence to support advanced care planning, the qualitative studies say it helps patients clarify their important goals and priorities. It enhances open discussion of dying between patients and their families and reduces the decision-making burden on families, and so that they're not left to make decisions that they don't want to make. The cohort studies and randomized control trials, they increase likelihood of the person being cared for at the end of life according to their wishes, improved patient and family satisfaction with care, better quality of dying and satisfaction with end-of-life care, reduced stress, anxiety, and depression in surviving relatives, and reduced aggressive medical care near death, giving people time to make decisions for what they want and discussing things openly. So I use this tool quite often because I find it very useful, especially in the nursing home setting. It's the SPICT tool, and you're probably all very, very au fait with this particular tool. This one's the SPICT for all, so it can be used by caregivers, families, close friends, and it actually takes, by disease, it gives you the clinical indicators of deteriorating health, which can be very useful, especially in my field where at any given time, over 50% of my patients have dementia with other comorbidities. This is a very sort of a visual way of showing people just what that deterioration looks like, and you sort of see the penny drop when you go through all of these criteria. But this is a time when people are deteriorating, we should be making plans for care now in the future and getting more support to provide the right care either in a nursing home setting or in their own private homes. So how can advanced care planning decisions be documented? So normally we would document in an advanced care directive, which is completed and signed by an adult, anybody over the age of 18 with decision-making capacity. It cannot be completed on another person's behalf, and it's recognized by common law in New South Wales. Every state has their own law about an advanced care directive. Advanced care planning decisions and conversations can also be that you appoint a legal guardian or a substitute decision maker, which is called an enduring guardian, and that person gets to make medical and dental decisions for the patient, which is different from a power of attorney who gets to make financial decisions around wills and money, etc. In an advanced care plan completed on behalf of a person, e.g. by a substitute decision maker, it should be prepared from the person's perspective to guide decisions about care. This is not legally enforceable, but hopefully the person chooses somebody who will respect their wishes and their values and actually see through what they've talked about. In a medical treatment plan, a medical letter outlining goals of care after an advanced care planning discussion, and a resuscitation plan. So the examples of enduring guardianship and advanced care directive forms, they look like those two forms there. The New South Wales Health one, making an advanced care directive, is actually a very helpful document and can be downloaded off the internet. And the other one, of course, is an enduring guardianship in New South Wales, which becomes a legal document. These forms are available on that website. So these are some useful resources. The Advanced project is really gaining ground with providing education to GPs and practice nurses about how to have advanced care planning conversations. Anybody can go onto this and look at their resources and tools. And then, of course, there's Advanced Care Planning Australia. And then, of course, the end-of-life communication guidelines. And then the New South Wales Ministry of Health Advanced Care Planning Information. And then the other two below.